I could stand here and pretend to you that the next couple of minutes is a function of the most elaborate choreography. That's not the case. This is a real-time experiment. Paul Bullen, my colleague here, who's much smarter than I am at anything to do with websites, is the chief architect of what you're about to see. And I'm seeing it pretty much for the first time. A couple of points though. I'm sure you're familiar with large organisations always trying to direct you away from people and to websites. Don't talk to me, please go to our website, www and the rest, right? Just so you know, and this is by no means a complaint. I made a decision when I first started here 14 years ago that I wanted to be in direct contact with the people I represent in a quasi-political kind of way. So as I think I've said a number of times to you in this conference, I'm the easiest person to find. And because a lot of people who Brain Injury Australia represents are low income, they often can't afford STD call costs. So Brain Injury Australia's 1-800 number comes through to my mobile. And if the phone in our offices aren't unanswered after 5 rings, it diverts to my mobile. So I like to think, again in my quiet moments, that everything that I do and say in a context like this is somehow genuinely representative of, built on the lived experience of people who contact me. So having said all of that, one of the things about websites is when I ask people, and I ask everyone who contacts Brain Injury Australia, how did you find out about us? 90+% of people find us through our website. So websites are important, particularly in a very, very crowded and sometimes competitive information environment. Any of you who work in the concussion space, for example, would know that there are manifold concussion protocols. Often very confusing. If you were a parent or a coach or a sports administrator, you wouldn't have a clue where to begin. So there were 2 principles that Paul and I were pursuing when we put this thing together. The first was plain English, not easy English, which I'm sure you're all familiar with, which is ordinarily pitched for people with intellectual disability. I wanted to make sure that we avoided jargon, used words of as few syllables as possible to make it as readily understandable from people who not only have cognitive impairment, but may come from low educational attainment backgrounds. So to give you a really, really good lesson in regards to severe traumatic brain injury in the Sydney metropolitan area where we are right now, half of those risk-taking 18 through 35 severe TBIs effectively occur between Parramatta and Penrith. And so that's where, as it were, Brain Injury Australia sits and lives. That's point number 1. Point number 2 is there's a whole literature on what's called choice architecture in websites to make them as easily navigable as possible. So we wanted to make sure, thanks, Glenn. Oh, it's gone to sleep. Anyway, so what we were trying to do with this is to make it as readily navigable as possible. So really, people who come to Brain Injury Australia's website are there for one of 2 reasons, sometimes both. About the injury itself, about the disability, and about the organisation and what it is and does. So with the assistance of Paul, what we've done is to make it hopefully really simple to navigate. So there's stuff about brain injury, about the organisation, definitions, about board and staff, news, and if you scroll down, the new stuff that's part of this architecture, I'll just go backwards if I can. Hang on. The new part of the architecture are these 3 buttons here effectively, which is there's a great deal of really detailed information about acquired brain injury and 2 different categories, severe TBI and concussion and post-concussion syndrome. And then further down the webpage, information about the organisation and what it does. Importantly, personal stories from people with lived experience of brain injury, and also 2 training modules as well, which I would certainly encourage you to have a look at, in traumatic brain injury and in non-traumatic brain injury. So that is a really, really rough tour. I want to do just one last thing. I'll give you an indication about how the interior of the website actually looks. And again, this is courtesy of the wonderful work of Paul Bullen, my colleague here this afternoon, this is the kind of thing that you will see. And hopefully it's easy to make your way around. And again, almost all of the information available is readily understandable in plain English and so on and so forth. So I just encourage you to visit braininjuryaustralia.org.au and spread the word. But now I'd like to welcome you to this keynote address on making the invisible disability visible. One of the things that the conference's organising committee has tried to do in recent years is to join the worlds of disability advocacy with the work and the potential breakthroughs of benefit that take place upstream of disability, including advances in diagnosis and assessment of injury, such as imaging. Which is why the committee was lucky that Professor Stuart Grieve accepted our invitation back to the conference after his debut, as it were, in 2018 in Brisbane, to update us on his work. Stuart is the Parker Hughes Chair of Radiology at Sydney Medical School, with an undergraduate degree in biochemistry, followed by a Rhodes Scholarship to Oxford University in magnetic resonance imaging, MRI, physics, and degrees in medicine and surgery. Stuart leads a research program focused on the use of cutting-edge imaging acquisition techniques and pragmatic clinical translation to improve, importantly, the practice of medicine, including the impact of concussion and mild traumatic brain injury. Stuart has authored 140 journal articles and received more than $8 million in competitive grant funding. Everywhere and always, including in conferences like this, Brain Injury Australia always tries to embed its advocacy in the lived experience, which is why we're also grateful that Stuart will be joined later by Australian Football League's Paddy McCartan. Paddy was the #1 pick in the AFL's 2014 draft, but his 8 concussions playing for St Kilda almost forced his early retirement. Unfortunately, due to Paddy's commitments to training with the Sydney Swans for their game against Essendon this Saturday, he has had to pre-record his presentation, and due to ill health, Stuart Grieve is joining us via Zoom. So please welcome Stuart.
Thank you very much, Nick, for the kind introduction. I hope you can hear me okay. Excellent. Apologies if I cough. I've been coughing a lot the last week and I didn't think I'd impose that on the audience. Today I'm going to be talking about measurements. I changed the title a little. Basically, I'm a radiologist and a scientist, and the picture you're looking there is, I guess, the peak of what I've been able to achieve in my science. It's one of my postdoc's brains, and the furry bit on the left are the fibres of his brain going to his occipital cortex, and the forceps-looking like thing on the right are his optic tracts going from his eyes into his brain. And that's a particularly relevant picture for concussion because a lot of the symptoms are in this system. I'm just going to kick it along. Okay, so I'm all about measurements, and this is one of my favourite quotes, which is from the business world, but essentially if you can't measure it, you can't manage it. I truly believe that. In my day job as a clinician, our role as a radiologist is to measure disease and work with other clinicians with that information to do things better, to do better diagnoses, to do better treatments, and to give better information about how things might go. So on the left are some pictures of normal type brains, and on the right some brains which I think you don't need a radiology training to recognise there's some things going on. There's a traumatic brain in the top left corner from a car crash with blood in the ventricles. The top right's a young chap who had a concussion in a basketball game. The bottom right's an infant who had hypoxic injury during birth. And the bottom left's a hemorrhagic stroke. All forms of injury and all relevant to what we're going to talk about today. So with this obsession with measurement, what is it that we're trying to achieve? It's pretty similar, I think, for clinicians and for patients, just the language is a bit different. So here is a list that's not exclusive, but it's most of the things that I'm thinking on with my clinical hat on when we try and do imaging. We're trying to exclude pathology. So in the context of someone who's had a traumatic brain injury, the primary thing would be to exclude pathology. And we can do that to varying degrees. If there is pathology, we want to be more accurate. We want earlier, more subtle diagnosis of smaller defects, and we want to do it faster and more available. We want to subtype people so we can give them more precise treatment that really matches what they have. And we want to prognosticate. So we want to give people a context for what's going on so we can make good decisions about how to move forward. And we want to guide other healthcare professionals to help, smooth that course and make management maximal. And also, we're trying to move ahead. So we want insights. We want to understand what's going on better. And that's a big part of where the science to clinical overlap occurs. At the patient level, basically you're going in, you're being brought in an ambulance to emergency sometimes, and you just want to know, am I okay? And if you're not okay, which is sometimes obvious, if you've broken a femur or something like that, you want to know exactly what it is that's gone on. And is there anything that can be done for what I have? And I think this is where it starts to get important for the meeting we're having now, because in brain injury, as opposed to a broken femur, as opposed to a heart attack, this is where it starts to get a little cloudy. And this is where I think we need to do more work in the medical profession to do better, to answer some of these questions better. So as I said, my day job's a radiologist. That's how I like to think of it. My night job's to try and do things better and to feed that back so my day job's easier. And we're pretty good at what we do in the main, the standard radiology. So big things happening, subarachnoid hemorrhages, dissections of arteries, strokes, things like that. Radiology is pretty effective, and brain radiology is a big part of radiology. That statement's true, except when it isn't. And in the setting of traumatic brain injury, unfortunately, it isn't a lot of the time. What we're quite good at is excluding the need for surgeons. So when you get in, you have a brain injury, you'll often do a CT, in some cases an MRI, and in about 1% or less of cases, there'll be something going on, depending on the history. And that might lead you to theatre, it might lead you to definitive invasive management. But most times, there won't be huge results coming out of that initial triage with CT. So how can we do better? So concussion's especially interesting to me. It's a big problem. I think everyone in the room believes it's a big problem, and socially across the world, we've been understanding just how big it is. The truth is, for concussion, as I said, most post-concussion CTs in the acute phase and most MRIs in the subacute and chronic phase are actually called normal. And you'll hear Paddy talking about some of the MRIs and studies he's had in the video we're about to show. Except clearly it isn't normal, because at least a third of people have ongoing problems that don't resolve over 3 months. And this can include so-called non-specific symptoms. And they're just called that because they're hard to measure. They're hard to put your finger on. And more measurable defects in cognition, attention, things like that. Importantly, there's an increased risk of psychiatric disorders with depending on studies, 50 to 80% of people having measurable features of mood disorders at 6 months. Okay, so just to give you a context, in the so-called day job, about a third of the MRI scans paid for Medicare are on brains. So we do a lot of imaging on brains, but most of these are for non-traumatic injuries. So they're things like strokes, multiple sclerosis, brain tumours and the like. And we do a pretty good job there. My position, however, is that this is just the tip of the iceberg, and the true scale of burden of disease is vastly unrepresented by that quite a large number of scans. So my focus has been on these invisible disorders, ones that are typically called normal if you did a completely standard MRI or other imaging. And they include brain injury that isn't severe, mood disorders, and early degenerative diseases. And the risks, as you can see in that blue box, are quite substantial and they overlap. And about 60% of us will be affected by one of these disorders: depression, dementia, and concussion. So mostly we're doing our work in the clinic on the tip of the iceberg, and I'd like that to change. This is all about the people who are living this experience. So I thought we could just pause here and hear from Paddy, because it's a pretty compelling story that he tells.
G'day everyone, it's Paddy McCartan here. Really excited to be speaking to the National Brain Injury Conference. I'm really sorry that I couldn't be there in person. Unfortunately, some footy stuff's come up today and I'm having to train, unfortunately, but I was really excited to be able to speak in person, hopefully, but obviously that's not able to happen. So really happy to be able to sort of send this video out and have a chat to you guys about sort of some of the things I've been through and some of the things that I've done. I know that it's been a bit of a disjointed couple of years for you guys, and Nick's done a really good job getting this off the ground. I know with COVID, it's obviously thrown a few spanners in the works, but yeah, it's really good. I've had a bit of a look into sort of some of the things that happen at this conference and some of the things you guys speak about and some of the things you guys do, and I think it's amazing. You guys do such a good job, and you should be really proud of the stuff that you're doing and the things that you're doing over the next couple of days to really sort of raise the awareness around concussion and sort of some of the things that are happening. So firstly, congratulations, well done to everyone involved and getting it off the ground in what's been a challenging couple of years. Yeah, I think, you know, when Nick asked me to speak, obviously I was going to have a chat with Stuart, but I can't do that, so I was just thinking back over the course of the last sort of couple of years and some of the things that I've been through and some of the things that I've done and some of the things that have happened to me sort of regarding concussion, and I was sort of having to think about where I'd start and what I'd chat about, you know, because obviously, you know, concussion is such a unique injury. There's so many different things that come into it, so many different things that can occur, and obviously everyone's experience with concussion is different as well. You know, everyone has a different perspective on concussion, the things that happen with it. So I think I'll just sort of have a chat to you guys a bit about my journey and some of the things that I've been through, where it sort of started and where it got to over the course of probably like a 5 or 6 year period when I was playing footy with St Kilda. I'll give you a bit of a background on just sort of my background and what I do and where I'm from. And then I was thinking at the end, I've got an Instagram handle, which is just my name, Paddy McCartan. And if any of you guys that are in the room now have any questions, any things that you want to ask me about concussion related or not, anything really, you can get on there and then send me a message and I'll get back to you for sure. Also, I have an online business which is called Helping Hands Mentoring, which is also can be used to. I do one-on-one Zoom sessions with people. I'm a type 1 diabetic as well, so people with type 1 diabetes, concussion or sort of mental health stuff, if they want to get online and have a chat to me, they can too. So if that sort of appeals to any of you guys, I'll give sort of the email address for that and also my website handle at the end. So firstly, I'm Paddy McCartan. I'm an AFL footballer. I'm 26 years of age and I currently reside in Sydney, so not too far from where you guys are today. I play footy for the Sydney Swans now, but that's sort of not where I've always been. I was drafted to the St Kilda Football Club, so for those of you who don't follow AFL too much, that's a team in Melbourne. And I was drafted at the end of 2014 with the first pick in the national draft. So for those who aren't too aware of AFL, there's a drafting system at the end of each season and teams are sort of given a draft pick based on where they finish on the ladder, and St Kilda finished last in 2014, so they had the first pick and they selected me, which was, you know, it was really exciting at the time. It brought sort of a unique pressure that not many people sort of go through over that time, but I really enjoyed my time there and really loved playing there. I met a lot of great people and really enjoyed it, but probably one of the biggest things that came from my time at St Kilda was a real association with concussion, unfortunately, which started in my second year there. So in my second year, I had 3 concussions. So I had none of which were, significant. They weren't significant sort of knockouts or anything like that, but they were enough that it sort of knocked me around a little bit. I had one earlier in the season where I was pretty fine. I was just a bit dazed after it. I ended up doing the tests and failed them, but during the course of the week, was fine and played the next week. And then I had another one about 3 weeks later, which was pretty similar. I felt pretty good after the game. I was a bit dazed again, but sort of came back and got back the next week. And then I had another one about 5 or 6 weeks later, and on the back of that, there was a bit of concern around a few things that were happening, and I ended up having about 6 weeks off. And with that, with those concussions, there was no real significant symptoms. I wasn't really unwell or anything like that, but there was, a couple on that third one, there was a bit lingering, and that's what sort of made it, hard for me to get back straight away. Back then, with the AFL now, they've got protocols in which if a player misses, a player gets concussed during a game, they miss the following 14 days. And in that time, they have to tick off a range of things. So that includes a SCAT test, which is like the sort of concussion test you do after a game, just with sort of some memory stuff, some balance things, a few things on those lines, and things that you have to remember. And that's sort of like a baseline test. So at the start of every year, you do a baseline test, and if you sort of don't meet that while you're doing the SCAT test, then you fail, obviously. So you've got to do that. There's some exercise stuff attached with it, some high speed running, some contact work, and once you tick all that off, then you get back. And you're right to play again. So that's sort of the case now. But when I first started playing, that wasn't the case. You could get back in a week, and that's what happened in my first few. So, in my first year I had 3, and I wasn't really concerned, to be honest. I was probably more at that age. I was young. I was 19. I was probably just more frustrated, to be honest. More frustrated in sort of some of the things that were happening to me and some of the things I was going through. Just wondering sort of why it was happening so regularly, whether there was anything going on. But I was young, I was naive, and I didn't really think anything of it. That takes me to my third year. My third year, I had a pretty significant concussion. I got kneed in the back of the head when I was playing VFL, and that knocked me around a fair bit. I missed a pretty significant period of time, missed a few months, and I went to the what institute is it called? The Florey Institute, which is in Melbourne, in Heidelberg. They've got a really, really good brain centre there. I did the first of what would be a fair few for me of a functional MRI. So this sort of shows. It's an interesting one to explain, but I sat in this MRI machine for what felt like an eternity, probably best part of an hour and a half to 2 hours, and they do like sort of a functional MRI on your brain, just sort of scanning some of the things that they can see in there. And on the back of that, I got a report back showing that I was fine. There was no sort of distinct stuff there that they could see. Obviously, it was the first one I'd done, so it was hard to sort of compare it to anything that I'd done before. But I did that, and on the back of that, I got some good results. I said that I was pretty fine. But it was more just my symptoms. I struggled a little bit to do sort of exercise and things like that for a little bit, and then that sort of turned, and I got back and started to feel better. The year after that, I ended up getting back to play that year and got through the rest of the year fine, which was really good. I felt good, and I think I had four or five concussions, but I sort of was feeling alright. I hadn't had any significant symptoms. I felt like I was getting looked after really well. I was coming back and wasn't feeling sort of any lingering effects, which is really good. So it sort of put my mind at ease a little bit, which was great. Then in my fourth year, I came in and I had a couple more. And then I think that was probably the year where I sort of started going, what's going on here? I had one earlier in the year where I was just a sort of standard one. I felt sort of fine after, not too bad after. I was a bit dazed after the game, but then got back. And played, I think, the next week. So it's a bit hazy for me, all the sort of exact details. Like, lots happened in between now and then, but I got back the next week, and then I had one later in the year, and that was really significant, and that took me back to the Florey Institute. I got hit during a game, and went back to the Florey Institute and was told I had to do another brain scan. and the functional MRI, I got in there, did that again for, what felt like an eternity again for a couple of hours. And yeah, there was some changes on the brain scan that I'd done compared to last time. Um, and that was, it was concerning. I was, as I said, at this stage, I was 22. I was young. I was a young man, playing footy, and I'd had, probably more than most in terms of concussions over that sort of, um, 3 or 4 year period. And yeah, it was concerning. There was some stuff there that it wasn't things that I had a lot of specialists. Michael McDeasy, who is the head doctor at the AFL now, he was in charge of sort of the concussion stuff at the AFL then. And he was fantastic. He was such a great support for me, and obviously my family and stuff as well, but my family, my partner Lucy. But Michael was great. He sort of said, look, there's no, look, to be honest, and it's the same with a lot of concussion stuff now, like they don't know all the details and they don't know all of the stuff that's associated with concussion, but they can just make their judgments based off, the best sort of technology that they can get. And the functional MRI is right up there with that. So they gave me a bit of an understanding of what they thought was going on, and set sort of some stuff in place for me to do. I sort of missed the rest of the year. So I didn't play again for the rest of the year, which was, that was fine. It was sort of not something I was worried about. I was just more worried about getting myself right. And, on the back of that, I put some things in place, did some rehab stuff for my head, and got back to feeling really good. I didn't have a whole heap of symptoms. I was probably, it probably took me a couple of weeks to get back to feeling fully right, which is probably a bit longer than normal, but the more concerning part was probably this functional MRI and sort of some of the things that was showing, and a few little spots in my brain that were showing that were a bit different. So it was definitely a concerning little thing for me, but I always felt really comfortable, as I'm sure a lot of people in the room have as well, with, sort of the support they get. They were really comforting. They made me feel like everything was going to be okay, and I had really amazing support from my family and from my friends and from my partner Lucy. She was amazing. So, I was young, but I was feeling all right, and at the start of 2019, I had a really, really significant concussion. I was off the back of a pre-season, and I felt really fit, felt really good. I was really looking forward to a big year, and in the AFL they have sort of the practice matches in the pre-season, and in the last sort of practice match, I ran back with the flight and copped a pretty significant blow to the head, and yeah, that was probably the start of one of the more sort of life-changing experiences for me with concussion, and it sort of altered the direction that my life was going to head in. To be honest, I was really, really sick. I went straight to hospital. I was I can't really remember a whole heap, to be honest, but I was in the change rooms. I was taken to hospital. I remember sort of not coming to it, but sort of I remember the next day I was in the hospital. It was at Ballarat, and in the Ballarat hospital, my partner Lucy came and picked me up, pushed me out of there in a wheelchair and put me in the car, and drove me back to Melbourne. And I just remember being really, really, really sick, having really significant headaches. Didn't have any energy. I felt lethargic. I felt like my head was going to explode, and that sort of feeling and those sort of feelings that I was having lasted for the best part of probably 4 or 5 months, to be honest. This was at the start of March, so the start of March this happened, and for probably March, April, May, June, I'd barely left the house. I couldn't exercise. I didn't go to the footy club. I couldn't drive. I couldn't go to a cafe. I could barely watch TV. I couldn't go on my phone. I really struggled to have social interactions with people, and speak to people, even on the phone. Just that sort of concentration and those sort of things really, really made me feel, quite sick and quite bad. And this sort of went on with no end in sight. I was seeing some specialists. I did the functional MRI again, and there were some changes in my brain. I saw a few sort of head specialists, like sort of physios in Melbourne, who sort of tried a few things with me, but nothing really worked. and it was just a really sort of dark time for me. There was no sort of end in sight, and that's probably one of the hardest things about concussion that I found is that you know you can be feeling really unwell, and you know, with, say, if I refer it back to sort of a sporting perspective, you speak about like a hamstring injury or a calf injury or a quad or you know, even like a broken collarbone. There's a fixed amount of time that takes to get right. There's a certain program that people will do and certain things that people will do to get those specific injuries right again, and generally at the end of that sort of time frame, then you're better. Yeah, and one of the toughest things probably for me with concussion is that doesn't occur. That's not how it works. It's every case with concussion is individual. A man I'll tell you about shortly once said to me that once you treat one concussion, you've treated one concussion. Sort of meaning that every one of them's unique. You can't have you know, the same program or same sort of response program written out for every concussion that you deal with. They're all unique. They're all specific in their own way, and that's sort of, you know, what makes it so difficult to treat. And I was in a really bad place. I was really struggling. I felt like there was no end in sight. My partner was sort of really struggling as well, seeing me go through what I was going through, and a mate of mine, Kobe Stevens, who played with me at the Saints, had retired the year previous due to concussion as well, and he suggested catching up with a guy that he saw by the name of Brett Jaros, who's a neuro-chiro in South Yarra in Melbourne, who was really highly regarded by Kobe, and he said helped him a lot. And you know, at that stage, I was just happy to try anything, so I booked in an appointment with Brett, and you know, from the minute I walked in there, it changed sort of my perspective on concussion treatment. You know, how things can be dealt with from a concussion perspective, and you know, I think the most important part is that he put steps in place that made me start to feel like I was on the road back to where I was before. He has a lot of technology that gives you a lot of quantitative data, which you know, was something that I found really important at that time. I think I've been seeing a lot of people who were just telling me things and not really giving me any data around what was going on. And I think with that, it's hard to see improvement. You don't really know where you're starting from, and you don't really know where you're going. So Brett had a lot of sort of eye testing equipment, a lot of things like with reaction time, things along those lines that I did. And he sort of thought that there was a few things going on, but he wasn't too sure. He had a gut feel, but he was Brett learned a lot of his stuff in America, and he sort of suggested to me that maybe the best course of action would be to go to the Neurological Wellness Institute, which is a center based in Chicago in America, and he did a lot of his training for the stuff that he does with some of the guys over there, specifically Dr. David Traster, who is currently in Miami with the Neurological Wellness Institute. He's opened up his own clinic there. And I was all in. I said, you know, whatever I need to do, I'll do. And, you know, I was really lucky that the Saints got me over there. And I spent 6 days at the Neurological Wellness Institute doing intensives. And obviously the American sort of medical system is quite different to Australia. In Australia, if you've got something going on or if there's things happening, generally you'll, you know, maybe do one session a week, or, you know, one session a fortnight for however long you need. In America, it's different to that. So I went in and did, you know, 6 or 7 hours a day for 6 days straight. I went in there, and just the technology was amazing. If any of you are interested to sort of see or see, you know, see some of the things that I did over there, or go through some of the stuff I did, message me on Instagram, and I'll send you some videos and some photos of the stuff I did. But basically, I walked in there, and Dave did a few tests. He looked at a few things, and he sort of figured out pretty quickly what was going on. I had a convergent spasm with my eyes, so basically, when my eyes were shut, they would cross without me being able to control it. So I don't know, you know, I'm sure a lot of you guys know what it feels like to cross your eyes. It's quite a grim feeling. That was happening to me all the time. So when I slept, when my eyes were shut, even when my eyes were open, it was happening occasionally. And this was really, you know, giving me such bad headaches, making me feel terrible. And basically went about retraining my brain and trying to fix that. And, you know, it was full on. It was really, really difficult. By the end of it, I'd sort of felt like I'd run a marathon a day for 6 days, to be honest. I felt terrible, and I was exhausted, but it helped me so much long term. Brett came over with me to America, and we went through everything that was happening there together, and came back to Melbourne and set ourselves on a path to sort of get right. I'd go in and do 4 sort of hour sessions, 1 hour sessions a week with Brett, and just retraining my eyes to stop doing this stuff. On the back of that, I sort of started to feel better. I started to feel like myself a bit more, and this was by about August, September in 2019. So, I got concussed in March, and I sort of took me, 6 months really to get back to sort of feeling half normal again. Towards the back end of the year, I started reintroducing some exercise into my life, which was really nice for, my mental health and well-being, because I think that's sort of one of the biggest things that took a hit, was just that, something that I've been able to do my whole life, which is exercise and things like that. It got taken away. So I think, off the back of that, I was really lucky to be able to start doing some exercise and things along those lines. And then with my footy career, there was a lot of people saying that I should stop, saying that I shouldn't get back, because of the risks associated with concussion and things like that. And I understood that. I was in the same boat, to be honest. I felt sort of quite anxious around footy. And then I had a meeting with the AFL, a few specialists from around Australia. They had a look at sort of my case, the things that I'd been through, the things I was feeling. Spoke to a lot of people that I'd done work with. And on the back of that, they sort of suggested that if I was really diligent with my rehab, worked really hard at sort of trying to fix what was going on, that it wouldn't be fixed straight away, but sort of in the short to medium term, I'd be able to feel better and feel back to what I was. And then they had no real risks, or they had no real concerns around me getting back to play footy, and they felt there was no risk for me, or no greater risk for me than anyone else in getting concussed. Obviously AFL is a contact sport and there's always risk associated with it, but they felt that there was no greater risk for me, and that's all I needed to hear, to be honest. That gave me a real sense of confidence. These guys are the best specialists in not only Australia but in the world, and they're giving me this confidence to get back and know that I'm going to be okay, and they don't think that I'm at any greater risk than anyone else. So on the back of that, I set out to return to AFL, and it's been a bumpy journey. There's plenty of ups and downs. The Saints said the club that I was at, they weren't really keen for me to come back and play, and they weren't really interested in me getting back and playing with them, which was disappointing, and that sort of that stopped me in my tracks a little bit. But I've been really lucky. I got back. I got myself really fit. That sort of motivation to get back to play was amazing, because I sort of had lost a lot of that motivation, and especially from a physical perspective while I was concussed. I think, I was a little bit depressed. I was quite weighed down by what was happening, and that carrot that sort of dangled at me to get back to play footy was massive, and sort of got me out of a bit of a hole, to be honest. So I was really lucky with that. And at the start of 2021, I moved up to Sydney. I didn't get drafted by the Swans, but my brother Tom plays up here, and I played last year in the VFL. I played the first half of the year, and then obviously all the COVID stuff happened in Sydney. I was really lucky that I went into the hubs with the AFL team. I got out of Sydney and went into the hubs and did that with them, and played in the VFL for the last sort of 8 to 10 games. And it went okay, and then luckily enough at the start of the pre-season, the Swans said that they were going to pick me up as a rookie, which I was absolutely ecstatic about. I'd done so much work to get back, and it was just such a great reward. My partner Lucy had been absolutely phenomenal. She's been an absolute rock for me, and without her, I don't know where I'd be, to be honest. I'd probably be somewhere not feeling very good. So she's been amazing. My family as well, my brother Tom, Charlie, my mum and dad, Matt and Joe. Their support has been enormous, and I think to be able to get back on a list, and back on an AFL list, and to be able to achieve something that I set out to when that at the end of 2019, when I met with all those specialists, I just felt really good about it, and I felt like hopefully they felt, my family and my partner felt really happy about that as well. And I wasn't really sure what was going to happen, but now I've played. I played my first game at the start of the year. I've played 13 games since, and really loving my time at the Swans, and absolutely enjoying it. We've got a big year ahead. We're around 15 now, and we're going okay. So hopefully we can make finals and have a decent run at it. But I had a little I had a head knock in round 6 against Hawthorn, and I was fine. I wasn't concussed, unfortunately, but I have quite a significant amount of PTSD surrounding the SCAT tests and the concussion tests. And when I went in to do the test against Hawthorn with the doctor, I started freaking out and had a bit of a sort of not panic attack, but I just, all the stuff I had to remember and the things I had to do, I just sort of couldn't do it just because I was so nervous. And that was the first time I'd sort of experienced doing that testing since, I had my last concussion, and I was really struggling with that at the time. And it was a really good learning experience for me. It was probably one of those things that I hadn't redressed since I'd been hurt, and it was a really good learning experience for me, for the doctors at Sydney, just a bit about how I feel around certain things with concussion, and that was it was annoying that I had to miss a week, and I felt all right, but at the same time I think it was a really good experience. It gave a lot of us an understanding into sort of some of the things I'd been through, and then for me also some of the things that the docs at Sydney are doing as well, and sort of how they have to see it and what they have to do. So that was a bit of a hiccup in the middle of the year, but I've bounced back from it really, really good. I feel great, and I think the main thing is that I just feel happy and healthy. I feel like I'm in a really good space, and I feel really lucky. And if you had said it to me in 2019, at the start of 2019, that in 3 years' time I'd be playing footy for the Swans, and I would have overcome a serious concussion and got back and played, and all those things, and been through what I had, I would have absolutely laughed at you. But life has a funny way of throwing things at you, and I've been really, really lucky to have amazing support across the journey and get back to where I have, and just be happy and healthy and doing something I love. So I won't bore you any longer. That's sort of a bit about my journey with concussion, some of the things that I've been through and some of the things that I've done. As I said, I've got a website called Helping Hands Mentoring, so it's just www.helpinghandsmentoring.com.au. If you want to go on there and have a look at some of the things that I sort of offer or do, feel free. I'd love to get in touch and have a chat. I do the chats over Zoom, so it's just a bit about concussion and some of the things that I've been through, but also listening to your experiences and sort of helping each other through the power of shared experience is sort of the main goal of the website. And also, if you just have any questions or anything that you want to chat about after listening to the chat, feel free to get onto my Instagram and send me a direct message, and I'll get back to you as soon as I can. I love being able to chat to people about their experience with concussion and some of the questions that they have. So don't be a stranger, and feel free to reach out. And just to Nick, thanks heaps, mate, for getting me involved. I know it's probably hasn't been ideal the way it's been done, but hopefully this chat's helped, mate, and you've done a great job getting off the ground with all the COVID stuff and getting it all done. So once again, thanks heaps, guys. I really appreciate you listening to my story. Hopefully it's given you a bit of an insight into some of the things I've been through, and yeah, hopefully it may have helped in some way, shape or form. So once again, thanks heaps, guys, and have a great day. Enjoy the rest of the conference. Cheers.
Oh, great. Well, what a completely inspiring story. I should say I spent the first 15 years of my life basically wanting to be Paddy or someone like Paddy. In fact, Kevin Bartlett, that was why I stuck up the story from 2017, I think it was, where the Tigers were looking to poach him after he'd had his first injury. I'm a massive Tigers fan, FYI. And Paddy was part of that winning team that stole the game in the last minute at the SCG a few weeks back. Anyway, so what really struck me from the story that he said was a quote from one of his treating doctors who said, once you've treated one concussion, you've treated one concussion. And that shouldn't be how it is. If we had better tools to understand the disease and characterize it, then the pathway should be clearer, and concussion should be like many other diseases where, as a clinician, you're recognizing patterns that are surprisingly similar. There's always the individual patient, but I think we need to move past the situation where you have to search as hard as he did to find the excellent treatment that he got from Brett and people like it. So the data is quite supportive of his experience. There's strong data now, mostly retrospective for various reasons, showing this is from pediatric populations, but there's similar showing mental health problems increased following concussions. These are our own data. We did a meta-analysis of all the available data from all the available studies with about 50,000 total people and showed a threefold increase in the risk of depression, lifetime depression from any concussion ever. And I was a bit surprised by that. It didn't seem to matter whether you had a concussion when you were a junior or an adult. It was always about 3, and it's pretty solid data. It's about confidence interval, so 95% chance of being 2.5 to 3.5. So it's basically 3. I think that's really high, and it's a really concerning number. So what is the current state, and how do we move from where Paddy found himself and many other people find themselves of having to navigate a complex journey because the signals are just not there clinically? So what is the evidence base currently for diagnosis? There are very good guidelines. There's an engaged clinical and research community. But if you compare it to other areas of science, medicine, like cancer, like cardiac disease, there's not a lot of what we call high-level evidence, and that's where we need to be. The data is highly heterogeneous. There's lots of studies with different groups. It's hard to understand when you look at the data. One of the reasons for that is head injury is hard to study prospectively. So what we call randomized controls trials are hard to do. The study numbers tend to be smaller than other areas, especially given the size of the problem. And, you know, I think we don't really understand the cause and effect in the same way we understand other diseases, if you compare it to COVID, for instance, or heart attacks. It's a bit unfair and perhaps provocative, but following Paddy's anecdote about his very successful treatment of his ocular symptoms, I jumped on Cochrane, which is the repository for high-level evidence, and tried to find anything that was close to what we'd call high-level evidence, and there really wasn't anything at all. And I think that's fairly typical of the area, and isn't really a criticism of the individual people working towards this. It's just where we are. So what is needed? First thing, which is mostly what I've been working on for the past decade or more, is better measures of the injury and the disease. The second thing, which is equally important, is bigger and better trials to test these and translate. And my particular area of interest is standardised data banks based around imaging. Obviously, imaging's mostly what I do, and it's a really good way to measure injury and disease. And the idea is to connect using phenotype measures of the disease with other medical and research data, generate better signals, link these to outcomes, link these to events in the future. So if you have an injury, what happens in 10 years, what happens in 5 years, and importantly, to test and validate these rather than just do one-off studies. 90% of studies are never replicated. That's overall in medicine. So I'll just jump to the left, and before I rip through into some actual imaging. So my other 50% of my research agenda is around heart attacks. So heart attacks are really worked out. I mean, if you think about if you have a heart attack and you present to hospital, you're whisked into an algorithm of care that's backed up by studies with 100,000 people in them. And it's very, very precise whether you have one therapy or another. It's very nuanced. Despite that, 50% of the risk in heart attacks is unknown and unpredicted. So we've put together a study called BIA, that's to try and find this other 50% so we can do a better job in heart attacks. And we're powering that. We've just expanded our goals to 15,000. I'd like to make it 50. And the key difference between that and doing the same thing in head injury is the existence of this test called a CTCA, which is called a CT coronary angiogram. So we do all this, we get the patients, we collect all the other data, all the other information, biological samples, bloods, cells, different things like that, and we match that to the phenotype. How's that different to where we are in the brain? Well, we don't have the equivalent of a coronary angiogram. We're basically at this stage. This is one of my favourite slides. This is what coronary angiograms looked in 1950. I mean, not great. I wouldn't like to be diagnosed using a picture like that. And people thought so much at the time. I think that's about where we are now with brain scans. The brain's a much, much more complex organ than the vessels in the heart. And in the last 20 years in medicine, we've developed a really excellent tool, which has really hit prime time in the last 5-10 years, which has stimulated BIA as a study. And I'm putting this here to contrast, I guess, where we are now in the heart versus where I'd like us to be in the brain. With CTCA, we can see the disease in health, in pre-disease and in fulminant disease. So we can see the whole thing. This is a plaque. This is the sort of thing that gives you a heart attack. We can
get things restarted. We are one of the challenges with these last minute changes to the delivery of these presentations. Up until this morning, Stuart was going to be live with us here today. Similarly with Paddy, because of last minute training requirements for the game against Essendon on Saturday, he was also going to be with us today. So timing has been a challenge. So I think we're going to rub up very, very close to the edge of 2:30. So if I could ask you, hopefully we'll be able to get Stuart back, but you don't want to listen to me rabbit on for 10 minutes. Regardless, if I could ask you to move fairly quickly to your
right
next
now,
choice.
I'll just flick back to the slide. So we've got this amazing test called CT angiogram. And it basically gives us a continuum from early disease all the way through. If we didn't have that, we'd have to wait, as a lot of studies have had to, for a heart attack to happen. You can imagine that's not that satisfactory, because what we want to do is prevent the damage before it happens. And this is how I see it. You've got your hills of health, you've got the sea of disease. We want to see all of it. So to effectively treat brain pathology, especially this so-called invisible pathology that a lot of brain injury is, I've started this project called Brain Passport, which is analogous to what we've done in BioHeart. To give you a context, in BioHeart, we're at 5,000 people. We're just funding it with an extra $50 million, we hope, in a few months, to 15,000. And that's the sort of power you need. So in Brain Passport, we've just reached 2,000 in our pilot group. We've had a bit of a pause in COVID. We've been building infrastructure, and we've got a bunch of what I call satellite projects. We've got a dementia study that is standardized to the Brain Passport model. We've got a depression study where we're looking at including pharmacogenomics to predict better outcome in depression. And we've got some concussion work, some work with motor neuron disease and people with genetic disorders that affect the brain. So that speaks to the slide I put up before of needing big trials with power to test and validate different measures. What I'll jump to now is, I guess, the bulk of what I've done, as I mentioned, in the previous 10 years, is better tools to see what we can see. So there's a chap called Charlie, not his real name. I imaged him at the SAN. He had a incident playing basketball where he had a concussion and a seizure. And he was probably the 1 in 5 that we get from that sort of population, where we do run some reasonably sensitive sequences and also some research ones. And you can see he's got some little hemorrhagic foci which have affected some of the tracts going to the front of his brain. And that will lead to some pretty profound consequences for him. If you don't have almost macro pathology like that, you need to use other techniques that are more sensitive. This is work from my depression studies, which shows a replicated signature of grey matter loss, which we can detect in people with depression. For this sort of thing, we need 30, 40 people to get enough power, so it's not enough on its own. Um, to do this, we've been searching for better techniques, and one of the most promising techniques is diffusion MRI. Just checking the time. And that is very sensitive. It is used clinically, but not a lot and not to its full power. We did a image-based meta-analysis of the changes that have been published so far in depression, and they were somewhat complex due to the mixed cohorts, but they showed strong, powerful signal across the brain, which was consistent with what's known clinically. So I think it really showed it is viable as a tool in routine care to treat those 50% of people from Parramatta to Penrith that Nick referred to. Our work in motor neuron disease used another type of diffusion imaging called kurtosis and showed a pretty promising biomarker to see early changes. We've also worked in international rugby players using the same technique and can detect changes in over 90% of those people compared to controls. And we can use other techniques, informatic techniques, to separate people by diagnosis using the same raw data. One of the issues has been that this technology isn't really ready for routine use. So it's probably in the same category as the good folk at the Florey, where yes, you can do it at a really high-end centre, but there's one Florey in Melbourne. There's a couple of similar institutes in Brisbane and Sydney, and if you're lucky, you can find a spot in that. But what we really need is something we can deploy on the corner of, Parramatta Road in the suburbs. And we've done a lot of work on sensitivity and specificity that hadn't been done before to try and deploy these techniques. We also probed the limits of resolution, and in this paper looked at mapping the hippocampus, a part of the brain that's highly involved in a lot of traumatic injury and memory. And we've looked at generating some biomarkers that reflect emotional performance as a logical step to linking the mental health problems that people like Pat have experienced and the primary injury to these fibres, which leads to that. Just skip those in the interest of time. We also played around with looking at signals that can predict response to drugs. In depression, there are effective drugs. The issue is only 30% of the people prospectively respond to those. So picking who can respond is an important thing. And when there are better agents to treat head injury of various kinds, that sort of thing will be important. Just some nice pictures to finish up, because I'd like to leave some time for questions. This is data I showed before. We've analysed it a bit further and we've extended it. It's just kind of neat, so I wanted to show it. This is data we got from the Mayo Clinic, where we looked at maximising the very possible resolution that could be achieved using MRI. And we looked at a structure called the optic chiasm. So that's the one I showed on my title slide, and compared the very best we could do with somewhat standard techniques. I'll skip that. It's a bit complex. But what you're looking at here is the X is where your left and right eye combine and then split apart to go to the rest of your brain. And they're pretty amazing pictures. And if we use tractography, you can see the representations of the brain fibers actually crossing across in that area of the brain. And the interesting result is we got quite close to the number that we know crossover, which is around 53%. Whereas if we just use best case standard, we only got 17%. So I'd say we're getting close to that kind of test, the angiogram test that I mentioned, that would permit large scale measurements of disease state in brain injury. I might just skip over these. These are some more advanced measurements of brain networks. So I might just finish there, just so we keep to time. But I think the future for my work, and hopefully working with Brain Injury Australia, is to extend what we're doing and start building a collaborative platform to really take the experience that someone like Paddy had to experience and making it a bit of a smoother route.
Thank
you.
Thank you. I think, Stuart, in a quest to make a seamless transition to the next sessions, we may not have time for questions, but thank you, and I wish you the speediest of recoveries.
No problem. Thank you, Nick.